I will invite Dr. Satanshu for his talk on posterior cataract, how to prevent posterior capsular disruption.
Thank you, sir. RP is very elaborately described the soft cataract management. When cataract is a very soft supracapsular or bringing the cataract into the antechamber, in the pupil plane, and then remove it is a good thing. But cataract is grade 1, that you have, whenever you are making a tunnel, sculpting, you should keep reducing the power of the power, so that when it start in place of cutting, it start grabbing or it can start holding the nucleus. That is the exact power, and then you can cut any type of nucleus in soft cataract. So there is no issue of cutting or dividing a nucleus in soft cataract. So posterior polar cataract always poses a threat to the any cataract surgeon, but if we follow simple tips, we can achieve a 100% success rate without any doubt. So what are the tips? First important tip is the First important tip is the careful preoperative awareness slit lamp examination of the patient. So if you are already decided in mind, this is the simple slit examination, vertical groove, where you can see the wall-like appearance, or we can see it is a slit-like, we can onion-like appearance, onion ring, bullseye. So we can definitely keep in mind that we are going to deal with a different type of cataract. We have to get preparation done in our OT. On the sides we are showing this is a PC thick and thin area, or you can see suspected PC rent there, because 33% cases of posterior polar cataract, chances of PC rent are there. So whenever we do hydrodissection, the fluid comes in this way and it come in this way. This is the nucleus. Fluid go behind the nucleus in this way to the weakened portion of the posterior capsule, and this cause increase in the rent and nucleus drop. The rent will increase and there is a nucleus drop. So we have to be very careful. We should not do hydrodissection at all. There are many techniques. I can show you 3 or 4 techniques where we can remove the posterior cataract without any hydrodissection. So you should know this is the area behind, other than the posterior capsular area. This is posterior subcapsular area. This is posterior subcapsular area. This is the onion. This is the posterior polar cataract area. So other than posterior polar, there is a posterior subcapsular area. So you should not get confused. This is the case for posterior polar cataract, where we make an incision. We have to do bimanual, so we made 3 port in this case. Normally we do not do bimanual in every case. Dye is very important, even if it's a soft cataract, because you have to not to lose the cut end of the capsular axis at any cost. Procedure are same. Capsular axis, important thing is there is tip number 2. We should have a sufficient adequate capsular axis, neither too big, neither too small. We have to keep the size small because we have to put sometime IOL in the sulcus over this capsule, because chances of PCN are there. The capsular axis is oval shape we are making. My friend from research, Charanjit Singh, is a very advocate of this capsular axis of oval shape. Advantage of oval shape capsule axis is that easy maneuverability of the nucleus, not much manipulation, and sub-incisional epinucleus and cotton removal is very easy in such cases. Now we have made a tunnel. So you see, this is soft cataract, we have made a small tunnel. Because we have more space now available, because capsular axis is oval shape. So we have more space now available to go up to the capsular margin. So more space we have available now. Now do see, we have not done hydrodissection. There are two ends of this tunnel, and here we are injecting the fluid to do hydrodelineation. Hydrodelineation is very good because it's all the fluid you are injecting is going in the nuclear space. This is not going behind the nucleus, because we are putting inside, we are opening the door, and inside the door we are injecting the fluid on both the sides. So there is no chance of going fluid behind the nucleus. So posterior capsule rent will not get increased. So this is the ring. We can get even ring like this by the hydrodilation. So no hydrodilation, good hydrodilation. If you require, you can do hydrodilation from other port also. Now we are pulling the nuclear part piecemeal from the sides. below the axis, and trying to physically elevate the nuclear part, because these are soft cataract. We are trying to elevate the the posterior polar part and trying to engulf it by the phaco. Central part we have left behind because there is a rent, we can doubt the rent there, we have left the eye. So pulling from the side, and now see, everything has removed and there is no dent there, so we are happy. But before removing the main ports, say from the phaco probe, we have to inject the viscoelastic not to allow the chamber to collapse. This is step number 3. And then we do bimanual aspiration to pull out the nucleus out, cortical matter, because we don't want to lose the chamber stability any time. It will increase the rent if there, or it will produce the rent. So gradually we are removing. Once removed, then again injective viscoelastic before removing the port from other side, and do the bimanual from other side. So it is a slow process. You should keep your cool. If you do phaco normally 5 minutes, do it in 10 minutes. So clear all the cortical matter, and once the cortical matter is clean, and then you find the posterior is good, then you can do implantation. So if you follow simple tips, then you can achieve 100% success rate in such type of lenses. You can put. The posterior polar is your mindset that you should not get afraid of it, but you should be ready for the vitrectomy. At least anterior vitrectomy should be known to all anterior segment surgeon, and they should do it. Cleaning has been done. If there posterior capsule, there are some, you can see some part on the posterior capsule, but we are not going to clean this part because it gives risk that posterior capsule can rupture there. You can see center there is some posterior dirty. We can get it care later on by the IR laser. So whenever you injecting fluid also, you should keep one. These are tips. Correct preoperative diagnosis, small but adequate access, no hydrodissection, gentle hydrodination. एक मिनट पीछे करना, एक मिनट बैक करना भी, नहीं बस लास्ट और लास्ट, आगे बढ़ो आगे बस. No nucleus rotation, AC should be maintained all the time, parameter should be low, phaco power we are using more hardly, एक मिनट फिर हो दो वापस. Phaco power you are using is 30 only, bottle height is 50-60 centimeter only, and vacuum and flow rate is 20-30 only. No panic. If there is a complication, manage complication efficiently. You should not panic in the OT when there is a PCR, because you are already expecting something wrong can go wrong. Thank you.
Thank you very much, Dr. Satanshu, for the wonderful deliberation on posterior polar cataract. Beautiful videos and wonderful technique you have used. You said you will not do the hydrodissection in any of these cases, and but there are reports and the publication, they say like multi-directional or multi-point hydrodissection could be of use in some cases. So what do you say that?
When we can get the best result without the hydrodissection, we should not take the risk. There one more technique that we had started doing now. It is one of my friend from Brazil, Tata Neto, is doing. That we are mechanically separating the, I will can show the video next time. Mechanically separating the nucleus. We are not doing hydro, we are not doing hydrodissection, and nucleus rotating like a spin like this. So next time we'll include that video also in my presentation. I am just recording it nowadays. So there are very good methods to, why should we take risks of the hydrodissection? Fluid can
chopper?
go.
You have that chopper? That's
Yeah, I got chopper.
Okay.
I got it made here. It can be really
It's available
very soon in the market.
okay, soon in the market.
Yeah, market
Okay.
soon in the market. So there is one more this hydro developed by Dr. Bhumi from the Calcutta itself, from Disha. He has got port not on the tip but on the side. So
Right,
when you do
right.
hydrodissection, fluid never goes behind the nucleus.
Right,
That
right.
I also tried this. I have a video also of this. Next time I will show the video of hydrodissection in posterior polar cataract, because that is a more important thing.
That's good.
Fluid go from the side. That does go on the tip, not behind the nucleus.
Not behind, yeah. That's nice.
That is another good technique of doing hydrodissection.
Yeah. Thank you very much. Thank